And for today, we have a trio of experts speaking about the fundamentals of program evaluation and impact. To kick things off, we have COASC-SF's leader, Dr. Carla Perissinotto, whose work on the health effects of social isolation and loneliness is well known. She has gained national and international recognition for her research. Dr. Perissinotto, please take it away.
Thank you so much. I have to say, it's so exciting to have this symposium underway. We've been talking about it for a long time, and then there's something called a pandemic that happened, and then there's something called a pregnancy that happened to me, and here we are a long time later. I'm going to ask folks, just so that we kind of know who everyone is. We're not going to go through introductions, but maybe in the chat, just write what organization you're from, anything you want to share in this communal environment of what excites you about what you do, what you're excited to learn. And if you want to be quiet and observe, that is okay too. We are non-judgmental and welcoming of all. So, and while you do that, I am going to share my screen. So give me 1 second. It'll be a little bit of convoluted. Let's see. And there we go. Okay. Y'all see my first slide? Okay, great. So this is our first slide. Wanted to share with you that we finally have our website up, which is the Coalition for Older Adult Social Connectedness. I am actually, as I'm seeing that it's a mouthful, I may need to reconsider making the name a little bit shorter, but in the meantime, that is what we got. And what are we doing today? So I'm going to spend a little bit of time talking about what has happened with COVID and loneliness and isolation based on some research we've done. I'll briefly talk about what are we seeing nationally and why are we having the symposium today. Then I will turn it over to Janet Myers, who is a professor of medicine, medical sociologist, and really an expert in evaluation. And I turn to her to everything. So I'm grateful to have her. And then Ashwin Kotwal, who is a geriatrician and palliative medicine physician and a researcher in loneliness and isolation, will talk to us a little bit about data collection. And then we'll spend some time on discussion and Q's and A's. Please add your questions to the chat. We will likely leave them until the end, unless Sohan will be sorting through and seeing if there's questions that seem like we need to answer right then. She might jump in and add. Otherwise, we'll save them till the end. So what's going on with COVID and isolation? So I wanted to share some data from some national work by AARP. This question asked, what has been the prevalence of social isolation specifically in older people? As you can see from here is that over half of people were experiencing isolation for themselves as well as a loved one. The other things notable from the pandemic is that not only were people experiencing isolation, but there was a whole slew of negative emotions as well. Feeling frustrated, feeling stressed, feeling isolated, feeling lonely. So this has clearly had a huge effect, not surprising to all of this. How does this compare to what's happened here locally? So our team here, Ashwin Kotwal and myself and with others, conducted a study with many of you as our partners looking at adults who were receiving care either at our UCSF geriatrics clinic or who were being part of programs such as Covia Senior Life and Curry Senior Center. We were actually calling people every 2 to 4 weeks, initially every 2 weeks, until people started getting tired talking to us, and then expanded it to 4 weeks as the pandemic went on. We really wanted to get a sense of what was happening with people in terms of their psychological well-being, their social connections, and key medical needs. What did we find? So in our population here in the Bay Area, about 29% of people were reporting frequent feelings of loneliness. In terms of was this better or worse during the pandemic? So for most people, it was worse, but for some, it was actually the same or better. Why is that? Maybe because suddenly we were paying attention to people and people were receiving services and outreaches, but kind of some interesting findings here. The other thing I wanted to highlight here is the last thing that we found is that 79% of the people we talked to had minimal to no video interactions. So this is important to us as we think about how do we move into the future? How are we outreaching to people? Are we doing it only by video? Is there a telephone option? And for people that don't have those options, how do we encourage outreach and make sure that people have those devices available? We also found that people had quite a few of substantial unmet health needs, problems with medications and food security. So this is a really bit of just a brief intro into what's been going on. Not surprising, probably what you've been imagining, but it puts it in some numeric forms what we're seeing. So why is this relevant nationally? So right before the pandemic started, I've never seen that actually light up that way. The National
you can use that
Academy
for
of
the garage
Sciences,
for the car.
just a reminder to please mute if you can. So the National Academy of Sciences published a report in February, right as the pandemic was starting, on what should we be doing about social isolation and loneliness in older adults, and what should healthcare systems be doing. So what is the National Academy of Sciences? So it's actually been around forever, since 1863. What's neat about the National Academy of Sciences is that they provide independent, objective analysis and advice to the nation to solve complex problems and inform public policy decisions. So what was excited about this is that loneliness and isolation have received such amount of attention that it was deemed a worthy enough topic to be proposed before the National Academy of Sciences to then propose policy changes and suggestions. And that's actually really why we're here today. The Academy was tasked with finding what the evidence for the health impact, and again, what is the role of the healthcare system. They went through some definitions to make sure we were all on the same page in terms of ensuring we understand that social isolation is about the number of contacts and the objective lack of social contacts, loneliness being the subjective feeling of being lonely, and social connection being in an umbrella term. What did the report highlight? These are things we're all familiar with here, I believe, is that there are tremendous health impacts, really ranging from major psychological, cognitive, and physical comorbidities. And unfortunately, one of the things that the report highlighted is that in at-risk or marginalized populations, we have very little evidence and so much work more to be done. The final conclusions from the report are that we need a more robust evidence base. We need to translate current research into healthcare practices. We need to improve awareness. We need to strengthen ongoing education and training. And the last one, which is again highlighting why we're here today, is how do we strengthen ties between the healthcare system and community-based networks and resources? This last one is really about how do we get to coordinated solutions? And with that, I will point to an organization called the Coalition to End Social Isolation and Loneliness. This is a national organization. If you haven't been to their website, I encourage you to go. I think you will see much more coming from them in the next couple months to years as we're working on really informing, again, taking the recommendations from the National Academy of Sciences report and moving forward to push forward a policy agenda. A sister to the coalition, to that group, is the Foundation for Social Connection. Now, this again is relevant to our work today because part of the Foundation for Social Connection includes a scientific advisory council, of which I am a part. The Scientific Advisory Council is reviewing any new evidence that's coming out, which includes evidence on risk factors and evidence on interventions. What does that mean for you? So one of the recommendations from the National Academy of Sciences report was to put forward a clearinghouse. A clearinghouse meaning a place, a repository of all the interventions and programs across the country that we believe have evidence for improving loneliness and isolation. So what does that mean for you? It means that for you, what programs you may be involved in are helping to lead or start thinking about start thinking about how are you addressing loneliness and isolation and how can you show that? Can you start gathering data? If you have been doing that, is it the right way or can we be improving that? And that's what I'm hoping we'll start to learn today to get you on the right path if you haven't already, or again, improving on what you're already doing. Some of this can be then used to refine your program. Perhaps as you start evaluating, you're finding that you're doing really well in some areas and not as well in others, or you're reaching some segments of the population, which is fine, or you want to have a greater reach. And then ultimately the goal is to submit your information to the clearinghouse. The way the clearinghouse will work is that For example, you may have, let's say, SIR can post their program up, and there will be a review, and it'll say, green, there's great evidence for its effectiveness, or it'll say red, or it'll say intermediate. And that way partners around the country will know how effective this program is. And the hope also in my mind is that some of these programs that we have will get some better financial backing, which I know many of us need. So that's the ultimate goal. And that's why I'm hoping that this symposium today can help some of you on the right path. And will open some avenues for some future discussions and questions. In sum, before I turn it over to Janet, I also want to thank the Joseph and Vera Long Foundation, who have graciously supported the starting of this coalition and are helping us to have these symposiums. And with that, I am going to turn it over to Janet. Janet, thank you so much.
Thanks, Carla. And hi, everybody, and thank you for having me today. Let me just share my screen, show you my slides, make them presenter view. Unfortunately, it makes it so giant on my screen. It's like it's a little overwhelming. Hang on, I think I still have to do that. Hi, everybody. My name is Janet Myers. I'm in the Department of Medicine at UCSF. And I happen to teach program evaluation in the Implementation Science Certificate Program at UCSF. I don't know if you all know what implementation science is, but it's really the study of applying evidence-based practices in the real world. So it's exactly what Carla was just talking about. That's really, I didn't know anything about your work in that foundation. So that's really interesting to hear about. And it actually, it really is kind of what I do for a living. And I'll talk a little bit more about that as I go along. But anyway, today I just wanted to talk to you a little bit about the history, about an overview of program evaluation, sort of program evaluation 101 and why it matters. I did notice in the chat that it's a pretty diverse group of people, and some of you have quite a bit of experience already in either research or evaluation. So you can help keep me honest, and please keep the questions coming. I think Sohan's gonna monitor the chat. So if you have questions as I'm working through these slides, please let me know. So this is what I just said. These are kind of the objectives of what I wanted to talk to you about today. So let's first define program evaluation. It's the systematic collection of information about a program in order, it is to enable stakeholders. That's not always the main reason, but really these are some things that you can do with it. You can better understand your program, you can improve program effectiveness, and you can make better decisions about future programming. I like this definition by Carol Weiss. She's no longer with us, but she was sort of the mother. She was one of the mothers of program evaluation. She defines it as, sorry, I have to move you guys. I can't see my screen all the way. It's always a problem with Zoom. There's not enough room on the screens. Here we go. Evaluation is the systematic assessment of the operation and/or outcomes of a program or policy compared to a set of explicit or implicit standards as a means of contributing to the improvement of the program or policy. So there's, the thing that I always, this always makes me think is that, there is a difference between evaluation and research. And evaluation is really intended to have utility. It's intended for a specific use. It's not sort of as objective technically as research. The questions are usually developed by the program, not the investigator, as would be the case in research. It has this judgmental quality. That's why I like that Carol Weiss definition, because it really implies standards that you have to kind of keep in mind. Let's see, it takes place in the real world, as I mentioned. Role conflicts can arise because program implementers and evaluators often have different priorities. Usually dissemination is different with evaluation. So these are all while we say that it's the use of scientific methods, it's important to consider that it is actually different than research. So why do we evaluate? Great question, right? So we evaluate to ensure program effectiveness, to demonstrate accountability, usually to a funder. That's a lot of what my work is. To contribute to a public health knowledge base by, by publishing scientific manuscripts and textbooks and things like that, and then to improve program operations and service delivery. And sort of the role and the purpose of the evaluator is different depending on these perspectives. So with accountability, you're really focused more on measuring results and assessing efficiency. That knowledge generation perspective, you're really trying to generate new insights and methods. And then developmentally, this is often when you're trying to think about how you're going to want to change a program or make some course corrections, you're building capacity and strengthening institutions. Here are some typical uses. Policy and government in the accountability way. That's, as I mentioned, a lot of my work is funded by the federal government. And so this is kind of where I live. However, I also work in a university and I have to get promoted. So I also work in this knowledge perspective space. So we do contribute to the research base around evaluation methods and also findings. And then developmentally, it's often for public policy. The role of the evaluator is a little different depending on their perspective. So the role sort of varies between distant or objective to close and a critical friend in the case of a developmental perspective. And theoretically, objectivity is high in accountability and knowledge and uncertain in developmental. I do want to mention that, you know, with evaluation, because there is that sort of need to think about locating your results relative to some standards, as Carol Weiss said, that the objectivity isn't as high as in something like research, where you're just trying to prove that the null hypothesis is not true. So anyway, it's not as objective as research. I think that's important to keep in mind. Just a little bit of history, which I actually personally find really interesting. People in education and health have been doing evaluation as part of their work for a long time. There's some good examples from the 30s and 40s. The war and poverty in the 60s marked the beginning of large-scale government-funded evaluations. And then there was something called the Elementary and Secondary Education Act in 1965 that had a requirement for evaluation under the law. There were other programs like the War on Poverty and the Economic Opportunity Act. That really, by the end of the 70s, evaluation had these programs and the requirements that evaluation be part of them really made evaluation commonplace across federal agencies in particular, and also in organizations, often in foundations, as you guys probably know. And at that same time, university research centers embraced evaluation, and evaluation was professionalized. It came to a little bit of a screaming halt under Reagan in the 1980s, as did a lot of things, unfortunately, but then made a comeback in the 90s with the Government Performance and Results Act. So that's a little bit of history for you. This is an important piece of evaluation because evaluators don't always work in universities like we do. They're held to some professional standards that come from something called the American Evaluation Association. These are the guiding principles for evaluators. And so the important part for me is, you know, when I do, we call it human subjects research. So a lot of evaluation has to do with asking people about programs and or observing people participating in programs. So there's usually people involved in evaluation. And when that's the case, I have to, as an evaluator and an investigator, have all of my work looked at by something called an institutional review board. And it happens at UCSF. So it's my professional duty really to have my work reviewed before I go out and start doing it. This is similar for folks who aren't in a university setting. You really have to kind of hold yourself to these professional standards. So they include systematic inquiry. Evaluators conduct systematic data-based inquiries, competence. There's a sort of a set, each one of these, there's actually a great website. The American Evaluation Association has a great website with more information about these things. Competence, there's a whole sort of, a set of standards around what competence is for evaluators. Integrity is another one. Respect for people. So evaluators respect the security, dignity, and self-worth of the respondents, program participants, clients, and other stakeholders. That's an important one. And then there's, you need to hold yourself to the common good and equity. Evaluators strive to contribute to the common good and advancement of equity. So these are the professional standards that evaluators require. Are there any questions? That's kind of a good spot for questions if anybody has any. I see stuff in the chat, but okay, great. Yeah, the Belmont principles. Yes, exactly. That's it, Pauline. See, I knew there were experts here. So let's see. So for me, the easiest way to talk about this stuff is to think about program planning or even program description. So when I teach this class, the first thing I do is I ask people to come bring a case, and you guys actually you all have them because you're all working in settings where you're actually implementing programs, right? So in the case of your programs, you very likely have goals, objectives, and activities. And goals are usually the big, broad, the biggest, broadest thing that the purpose of your program or the thing that you're trying to achieve. Objectives are usually more specific and measurable and help you sort of think about, you know, in a less broad way, but in a sort of just basically they help you sort of organize your activities into measurable ways. So with that in mind, evaluation can be conducted at each level. So at the level of goals, we call it impact evaluation. At the level of objectives, we typically consider that outcome evaluation. And at the level of activities, we consider that process evaluation. And I'm going to talk a little bit more about that if I can get my slides to move. There we go. So just by way of an example, I wanted to have an example for you guys from my own work. So the Ryan-White program is a big, it was a piece of federal legislation, it still is, but it's a federal program that funds lots of things, including HIV care for people who can't get it any other way. So it provides care for the most vulnerable people living with HIV through grants to cities, states, some organizations. San Francisco gets lots of Ryan-White money, less over time, but right now across the country, Ryan-White serves more than half a million people annually, mostly in community health centers. The first was authorized in 1990. It, as I mentioned, is the payer of last resort. The important part of this is there's a piece, I think it's part F, of the Ryan-White program that's called the AIDS Education and Training Centers program. And it's a network of regional centers, including one in the Pacific region, that funds targeted multidisciplinary education and training programs for healthcare providers treating people with HIV. I, for years, served as the evaluation center for the AIDS Education and Training Centers program. We don't have the contract anymore, but there are some good examples from my work that I wanted to include here. So here's some goals, objectives, and activities, right, from the Ryan-White program. The goal of the AATC is to improve delivery of high quality, state-of-the-art care and treatment to people living with HIV in publicly funded settings. That's the goal. How did we do that? Or what are some more objectives, targeted objectives? To deliver HIV-specific didactic trainings to 1,000 trainers in fiscal year 1920. So that sort of illustrates how you're getting more specific and measurable there. And time-bound is the other, I'm sure people know about SMART objectives in this crowd. Another objective to deliver high-quality capacity building assistance to clinics, aiming to improve their capacity to see and treat HIV patients. So, and then underneath those, you have the set of activities, kind of the widgets, the things that you have to, the processes and the pieces that you implement to get to your objectives. So in this case, activities include identifying trainers, training the trainers, registering participants. See, so the activities are really about just the sort of day-to-day work. In the case of SIBA, it would be something like identifying clinics, conducting needs assessments, designing and carrying out a tailored SIBA plan. SIBA's done. And then the next step in evaluation, of course, is to identify the indicators that help you measure whether or not you're achieving those goals, objectives, and activities. So an impact indicator is what we call that, or excuse me, a result of sort of impact of evaluation, sorry. I was eating pistachio nuts right before I got on it. That was a bad idea. The percent of patients whose HIV viral load becomes undetectable in that instance. So an impact indicator is a big, broad, sort of longer term sort of way of thinking about whether or not you achieved your goals. In terms of objectives, outcome indicators might include the percent of providers who you trained who scored 90% or more on tests, and also say they'll be able to apply what they learn. In training evaluation, that's a pretty typical way to think about that. In the case of SIBA, an outcome indicator would be something like percent of clinics receiving your capacity building assistance in accord with the plan that you developed. And then process indicators, and we sometimes call these implementation indicators. are these things measuring your widget. So number of people trained, number of trainings delivered, et cetera. And in the case of SIBA, number of clinics. So hopefully you'll get the logic. So in summary, program evaluation is critical for understanding how and well a program or strategy works, and an evaluator's perspective is important in the process. I won't talk about that second bullet. I think I talked a lot about it. I guess the other really important bullet on this slide is evaluation requires specific skills. So it's research in the real world. And I like to think that evaluators are even a little bit more nimble than traditional researchers, because we have to deal with so much noise in the system. And you have to really think about how to apply systematic inquiry in a real world setting. That's the first part of what I wanted to talk about. I don't see any questions, so I'll keep going. Great. So there are 4 general types or components to comprehensive program evaluation, and I just talked about them. So just to review, these are in the opposite order: impact, outcome, process, and then formative evaluation. I did want to just touch on. Formative evaluation typically happens when you're designing your program or when you're thinking about how you want to change your program. So this is another way to sort of describe how each type of evaluation corresponds to a stage of the program. Yeah, formative evaluation, I think I have a little more information about it. Yeah, so before you fully implement your program, it ensures that what you've designed is feasible, appropriate, and acceptable. It's funny, in implementation science, which is kind of, there's a whole big history around how that became a thing in the university. We also examine these things downstream when we're actually using strategies to implement an evidence-based intervention, but this is really about program design. So it's usually conducted when a new program or activity is being developed, and it's often concerned with the inputs, just to make sure that your program design is going to work. It's good for diagnosing program elements. It's also diagnostic of the extent to which an evaluation is possible. We sometimes call that evaluability. So before engaging, this is kind of an important point, because before you want to engage in a broad scale evaluation, you want to make sure that what you're evaluating is actually, it makes sense to spend the resources doing that. It does also allow for modifications before full implementation, and it really does help maximize the likelihood that a program will succeed. And it isn't usually as big or as broad a scale as process and outcome evaluation. It's usually, formative research methods include a lot of qualitative interviewing. They include document review, but you're not necessarily going to collect a survey of 300 clients to do this kind of evaluation. The next thing I wanted to talk about was process evaluation, or some people call it program monitoring. Especially, I think folks, in international programs use this term a lot, it's the same thing basically. So process evaluation helps determine whether your activities, the stuff that you're doing, are being implemented as intended, and they actually result in the outputs you expect. So I often think and stress that program evaluation is as concerned, if not more, with process evaluation than outcome evaluation. And I think that's true. It's like, I don't know, maybe because, I was trained in the university setting, people had a tendency to think of outcomes, patient outcomes, program outcomes, but the process piece is equally as important, especially because you want to be able to determine whether or not the outcome that you achieved was due to the intervention design, or whether it was implemented as intended. So those are really important questions. Process evaluation is critical because you want to unpack the black box of evaluation. That's a pretty common term. So, you put stuff in, and if you don't measure you're delivering it, or how things are into place, then you're not going to be able to get your. Did I mute myself? Did I mute myself? Can you guys hear me still?
Yeah, we can hear you.
Oh, good. Okay, how strange. That was the weirdest thing that's ever happened on Zoom. Okay, let's see, where am I?
We just didn't like what you were saying, so we just decided.
I guess so. People are like, forget it. I'm only doing outcome evaluation. I'm just going to mute you. You're over. So it is, I have to admit, it is kind of one of my favorite pieces of programs to evaluate. Of course, I care about the outcomes, but I have this sort of dialogue with my statistician all the time about whether or not we have to measure patient outcomes in every single study, because we know that the evidence-based intervention works. Do we really have to study again HIV viral load because we know it works? You know, anyway, it's sort of something that happens sort of behind the scenes a lot. So process evaluation questions, here's some key questions, sort of who's served, what activities are provided, when did they take place, where did they take place? There's the who, what, when, where, why is kind of process evaluation. Let's see, and it's as I think I mentioned all these things earlier. Design, implementation can be diagnostic, and is basically if you have a requirement for program monitoring, this is kind of what you're going to have to do. That's process evaluation. Here's outcome evaluation. So this is something I think we were all trained to do in our, you know, our science classes growing up. It examines the effectiveness, goal attainment, and unintended outcomes of what you do. In simple terms, the question is what's different as a result of your efforts. It can gauge the extent to which the program produces the improvements it intends to. Here's some good, sample evaluation questions for outcome evaluation. Was the desired change attained? To what degree did the desired change occur? What aspects of implementation were associated with the outcome? These are all outcome questions. It's very good for demonstrating the extent to which a program is having the effect on the target population in particular, or just, or on whatever. It doesn't have to be a population, it could be a clinic or a setting or an organization or whatever, but it does tell whether the program is effective in meeting its objectives. And then just a note about impact evaluation. We don't always do this. There's some people that kind of specialize in it. There's a guy at UCSF named George Rutherford, who you guys have probably seen in the news a lot lately. He does, one of his specialties is impact evaluation. So he does like country level stuff. So he uses big country level indicators of, you know, morbidity and mortality to determine whether or not these big policy level interventions are working. So that's kind of what more impact evaluation is about. It can demonstrate the degree to which the program meets its goals, and does often provide evidence for use in policy and funding decision-making. So how to choose what kind of evaluation you want to do. Planning a good evaluation requires understanding why and when each type is useful. Once you determine what you wanted, what the purpose of your evaluation is, there are a lot of designs that can be selected. You know, pre-post design, you can do sort of a multi-data collection sort of strategy over time. You can do one time with retrospective data. There's qualitative, quantitative. So there's a lot to unpack once you decide on kind of what you want to be able to do with your evaluation results. But really the program stage and scope will determine the level of effort and methods that you use. This is a summary slide. I won't read it for you, so I don't make sure I don't run out of time. Let's see. And then I just a couple of, there's some odds and ends here at the end of this talk I wanted to just mention, and then maybe we could have a bit of a discussion. But so as I mentioned, there are lots of methods that you can use. Implementation science is, you know, program evaluation is a piece of implementation science, usually the downstream piece. There's a bunch of other sort of research designs and methods that people use in a little more upstream in implementation science. But that's been one of the beauties of implementation science, is kind of adding to the toolkit of evaluation. So there's UCSF has some methods classes on how you can pick and choose among qualitative and quantitative methods for your evaluation. Qualitative methods are activities like, you probably know this, conducting interviews or focus groups. They can also be observations of a system or a setting, and document review. We do a lot of document review, especially when in government programs, people write a lot of progress reports, right? So you might think that's a waste of time, like I often do, but we actually are able to use those as data sometimes. So that's actually a good use of something like a progress report. Quantitative methods are activities like conducting surveys and abstracting and using medical chart data, things like that. Evaluation, as I mentioned, can be as rigorous as research, and often is in the context of implementation science, but it's typically more concerned with understanding how the program operates and having true utility to the people doing the evaluation. That's like as important as the rigor. Sometimes the rigor complicates things. And you spend all this time thinking about something like a stepped wedge design when you could get just as good a data by going in and doing some really targeted, excellent qualitative interviews. So this is what I wanted to ask. These are questions for you, or this is a question for you all. So what can program evaluation do for you? These were some things that I came up with, but I'd love to hear more. Like after hearing me talk, and you probably have examples from your own work, can you tell us what's evaluation done for you? And here's 3 things I was thinking. It can prove your work. It can prove your work and the resources it requires are worthwhile. It can. That's what I try to do, especially for people with HIV. I got into this work because I was an advocate. I was, doing ACT UP stuff and working in the policy center for the San Francisco AIDS Foundation. And so, I will admit to you, I'm not objective because I really am trying to advocate for funding and for programs for people with HIV. So that's just that's the reality. It can help you understand what internal processes need to change. That's that process evaluation piece. And that one, I really, as I mentioned, the other sort of benefit of implementation science nowadays is we use these sort of frameworks that really help you organize your thinking around processes and around different kinds of strategies and really digging deep on what you're actually doing. And that actually is another benefit of sort of the professionalization of implementation science. And then the other thing I thought of is it can help you think about course corrections and strategic planning. So what do other people have thoughts or ideas? Great. Let's see. Program evaluation helps staff understand the impact of their work and keeps them connected and driven to the mission of the work. Absolutely. It helps to understand how the staff inputs are tied to patient and client outcomes. Yeah, I couldn't agree more. That's absolutely true. And as a matter of fact, sorry, go ahead, Greg.
No, go for it, Janet.
Well, I was just gonna use our work as an example. I think, is Ashwin gonna talk about this stuff?
He may not specifically, so he's going to just talk about data collection, but go for it. Talk about it.
Okay, well, I'd love to hear what Daniel has to say about it because it was so, so we just finished up a study where we did interviews with homebound older adults in the Tenderloin. Carla asked me and a colleague of mine, Shannon, to help with the qualitative piece because that's, it's one of our specialties. And I got to say, the results of that evaluation were incredibly rich and so satisfying. I mean, at least to us, we don't get to do this work much, but wow, what satisfying work. So yeah, that was a great experience, I'll say.
I was just going to say that it's really nice to see exactly the inputs tied to the client outcomes, because I think sometimes we look at these so separately and not realize how they're connected. And there sometimes can be fear amongst staff or colleagues that like, oh, you're going to make me work more, and it's like, well, let's actually see if what you're doing is helpful.
Yeah.
Because maybe you're spending more time in one area and there would be better time in other areas. And so how do we do that? Yeah,
I couldn't agree more. Yeah, and people do, I mean, it's interesting. I feel, even the National Evaluation Center, the AETC National Evaluation Center, when we first got that grant, I think the AETCs were nervous that we were going to be going in there and judging them and measuring their work. And then, I don't know, sometimes you're right, that can be kind of threatening to people, but, like I said, I have full interest in making sure that, they continue to get the resources they have and that the good work that story is told. But on the other hand, one of the evaluation standards is data driven, right? So if something isn't working, you have to figure out a way to be able to tell that story too, in a way that that doesn't necessarily threaten the folks that you're working with. So it helps to have a good relationship, I think, between the evaluator and the staff.
I'm curious what you think, Janet, or what others think about that. So many of our funding agencies focus on, what I call you had a name for it, but the bean counting, which is really just like how many numbers of people, not really looking at other outcomes. Like what's that all about?
That's a great question. I think people, it depends on the agency, I think. And yeah, I don't know. What do other people think about that? I mean, it still happens, right? I mean, in PEPFAR, there's this big international program that funds HIV work across the world. And for years, the first round of PEPFAR They did. It was just how many condoms are you handing out? How many abstinence-only brochures are you handing out? Stuff like that. And those were the indicators. But then it got much more performance-oriented. You know, it also changed from condoms and abstinence only eventually. But you know, it really was how they were tied to big country level stuff, but it really was things that were more about performance. It was sort of more performance based. I feel like that's happening more and more, but I could be wrong. Let's see, I was just going to give you guys an example. This is a little wordy slide, but this is an example from the ATC program. So we got some money to look at the impact of clinical capacity building. And what we defined that was training based on chart review. So we went in and did chart review. It was also a handy way to collect data. So we went in and did a chart review and then sent a clinician in at the same time. And actually the clinician did the chart review. And then they designed a training plan for that clinic. And we did this in 34 clinics all across the country. And then we went back in, I can't remember what the interval was, but we went back in and assessed adherence to clinical practice guidelines over time. And so when we did, and we looked at that, we looked at some clinics that got the feedback and then the training and some clinics that didn't. And we found that there was an 11% increase in adherence to clinical practice guidelines, which is actually huge in the context of a clinic when you're talking about, you know, trying to, these are pretty, you know, the ATC clinics, I guess it depends on the clinic, but anyway, 11% was a pretty big change, we thought. And so did the funder, so did HRSA, Health Resources and Services Administration. Anyway, we tried to demonstrate with this study that chart abstraction and training was useful in assessing clinical practice and facilitating conversations about quality improvement, and then and actually in determining the effectiveness of clinical training. I think that's about all I got. I'd love to hear more about what other people think. Let's go back to this slide if you don't mind. We still have some time. And if you guys have any, oh, here we go. For us at COVIA, program evaluation can be a tool to involve participants and hear from them what their needs are. Absolutely. It can also be a tool to help make the provider-client relationship more dynamic, reciprocal, and ultimately effective. Yeah, that's a great example. And can I ask you a little bit more about that? How do you do surveys and things with clients, or do you do interviews? And do you have an evaluator to do that, or is it just part of your clinical practice? How does that work?
Yeah, I can share.
Great, I'd love to.
So yeah, so we do surveys, and actually it's most of it is just done by staff, but we have also, like, for example, some loneliness surveys were developed with, you know, UCSF and Carla. Hi. Very thankful for that. But yeah, it's a lot of just our own staff work, sometimes volunteers as well. And it's surveys. So we have a couple of different surveys. And then we also make it accessible like online and through phones. So there's different, for people who are online, there's different mechanisms that they can reply, just to make it easier to get more input and more surveys.
That's great. I love it. That's fantastic. So it's part of your culture.
Yeah, we really try to make it part of our culture. It's very much ingrained. So there's a lot of different opportunities for people to voice their feedback. And it goes even just beyond surveys. We also have sort of like community forums where people can give us their feedback and their input about what they're thinking of.
That's great. I love that. Yeah, we do that too in the context of, you know, often dissemination. And then it definitely feeds into the next thing. But, you know, one thing, I work in the Center for AIDS Prevention Studies, and we're very community-based people. Like, we've been, you know, in the HIV community for, you know, years and years. So one of the things that we're really encouraged and sort of hold ourselves accountable for is disseminating evaluation results. And we usually do community forum type activities at the end of almost all studies. And then we used to do, I actually really miss this, we had a conference every year, and that was a great opportunity for people from the community to come talk to us about our research and you know, what makes it helpful or not helpful, and to drive kind of the way that it moves forward. So yeah, I actually love that idea. And it doesn't always come up in an evaluation context, that's for sure.
I wanted to comment on what Pauline wrote about the client input being it's so funny, or not funny or sad, that it's like such a critical piece, yet something we forget all the time.
Yeah.
You know, increasingly you're seeing in healthcare more patient advisory boards. You see some of the newer funding mechanisms like the CORI, where that is a core part of what you have to do, is make sure that you are including actually the perspective of the people that you're working with. So thank you for bringing up that point, Pauline.
Yeah, absolutely. Yeah, I have a PCORI grant right now with an investigator at the San Francisco Department of Public Health. His name's Al Liu, and we built in, you know, 4 or 5 different ways to have a consumer perspective, also perspective. So, you know, like sort of the end users. And PCORI requires you to use these indicators that are patient reported. So you have to have the patient voice in there, and they won't fund anything that doesn't. So that's good. I do. We pay a little bit too much lip service to it. You know, it's not easy to have, you know, to find folks who are willing to do this. And then also to figure out a place where, you know, their voice can really be central. So there is something called the meaningful engagement of people living with HIV, which is sort of, it's this whole sort of agenda around making sure that people with HIV are at the table for research and evaluation activities. So I feel like, you know, there's the policies like that really help drive the inclusion of people. But yeah, you're absolutely right. It's pretty critical. Yeah. I mean, vaccine hesitancy. We're sitting in the middle of all this COVID work, and the voice of people who are and are not willing to, you know, accept the interventions are incredibly important, like critical. How can you can't do vaccination without understanding how people feel about it. That's for sure. Other people have any other examples of evaluation from your settings that you want to share? Anybody doing anything innovative or radical or not? Andrew?
Yeah, sorry, this is Andrew Broderick from the Tech Council, San Francisco Tech Council. So we use a lot of kind of technology in trying to improve quality of life. And if I took an example like, you know, social isolation, and we're trying to demonstrate its effectiveness. So I was kind of just asking Carla there, you know, when you're looking at an evaluation and needing an IRB, and we're CBOs, you know, what are some of the kind of good guidelines for how you might cost that out? You know, if you're looking at maybe 50 individuals and you're doing it over 6 months or 12 months, and you need that evaluation component, and you have to hire somebody or or build in an IRB kind of protocol for that.
That's a great question. I think so. I think it would be nice to have a researcher, right, to be able to write your IRB application in particular. I mean, some people have evaluation capacity in their organizations, and I don't know if you do, but you know, it's nice to have, but it's not always common. We have lots of people coming to CAPS and saying, hey, we're looking for an investigator to work with. Not always. You know, it takes a while to develop that relationship with university-based investigators. There is, if you find the person who can write the thing, and it's not the hardest thing to do in the world. If you're trained, there's something called a city training that should help you figure out what goes into an IRB application. But then there are these private ones. UCSF will they'll only review stuff that has a UCSF investigator on it, because they don't, it's a lot of work for everybody. But so I often recommend to community-based organizations who need to do this, the Western IRB. There's something called the Western IRB. They're it's one of many private ones, and they aren't too expensive. We're working with, I'm doing this study right now. Oh, good. Pauline says that's the one they use. We're doing a study of the initiation of a new provider training program across 15 clinics in the country, and there are a couple of the funder wanted a review of everybody's protocols. So a bunch of our sites, for some reason, UCSF wouldn't look at them, because even though we're the data center, they wouldn't go, because we weren't getting actual data from them. Anyway, it was complicated. My point is, We sent those folks to Western and IRB, and it was $1,100 per review of protocol. They weren't very complicated and they were very similar. So maybe that's a little less than it would be otherwise, but I thought that was pretty reasonable. $1,100 for an IRB is pretty good.
That's pretty good. Thank you. Yeah.
I think the other thing I would think, Andrew, is that, and I wrote this a little bit in your chat, is that the line between research and quality improvement is becoming more gray.
Yeah.
And I have had projects that are very similar, and one of them is considered quality improvement and one of them is considered research and needing human subjects protection. So think about it also, if you are doing if the questions you're asking are really to think about, are you trying to improve a certain product or service, you can think about that more as quality improvement versus, this is so hard sometimes. Are you trying to just answer research? I'm doing a terrible job explaining this at the moment.
It's so hard. I've had the same conundrum. It's really hard to describe. I think sometimes I used to think it was generalizable knowledge. So if you're going to write an article or, try to, talk about it at a conference, then it's research, but that's not anymore. That's not true anymore. Now it's just, they're sort of, they're qualifying everything low risk that involves human subjects as quality management, right? Or
Yep.
But I don't understand.
I think the reason I bring that up is because you don't necessarily need to go through the entire IRB process, depending on what you're doing. But still, I think going back to some of the fundamental principles you gave at the beginning, Janet, is that still remembering we still have a responsibility to protect information and private information we're getting from our patients or clients or population. So that's something to be thoughtful about. The involvement also with either UCSF or another academic institution can be as involved as you want or as limited as you want. You can certainly engage, faculty or groups on a consultation basis versus really having them full on take on your entire project. So there's different ways to do this also, which is interesting in terms of, we could, just to give an example, we have helped groups design their evaluation instrument and set up databases, but we may not be the ones doing data collection. If we're doing data collection, it's a lot more costly and involved. If we're doing data analysis, it's a separate thing. So there's different ways to do this. And so there's options to think about.
Great questions.
I think what we might do is Ashwin should be starting in about 5-ish minutes. Sohan, is that right? We're thinking maybe giving people a 5-minute stretch break, life break, and then come back. Does that feel reasonable?
Yes.
Okay. All right. So take a 5-minute break and come back at 3 o'clock. Sound good? All right. See y'all.
Give folks a few more minutes to come back from the break. I think we can get started now. So next up, we have Dr. Ashwin Kotwal. Dr. Kotwal devotes most of his time on research, focusing on understanding and enhancing social connections of older adults to improve their quality of life and healthcare access. His research interests involve evaluation of community-based interventions to address loneliness and isolation, particularly among older adults with cognitive impairment or approaching the end of life. Dr. Kotwal, thank you for joining us today.
Hi, thank you all for having me. I'm really excited to be here. I'm going to go ahead and share my screen. All right, can everybody see that okay? Excellent. All right, so today I'm going to be discussing strategies to measure loneliness and social isolation among older adults, and data collection considerations if we're thinking about evaluation studies or just understanding our communities a little bit better. I'm really hopeful that this will be an interactive presentation, so feel free to stop me if you have questions, and I'll also be posting some questions to the group, so hopefully we can talk through these topics. I know it's getting a little bit later in the afternoon, so feel free to also grab your coffee. Okay, so we'll be discussing two primary topics. The first is definitions and commonly used measurements of loneliness and isolation. And the second is primary data collection among older adults and populations at risk and some of the key things to consider. So first, let's think about definitions and measurements. So a lot of what I will present is based off of the recent National Academy of Sciences report that was published in February of 2020 that Dr. Personotto was able to participate and lead large sections of. And one of the key recommendations from this report was to develop a more robust evidence base. And I think the best way to develop this robust evidence base is by collecting data and by using systematic tools that have been validated and are widely used so that we can find ways to compare apples to apples when we're thinking about interventions, and also systematically measure what's most important. So to take a step back, when I think about loneliness and isolation, social isolation, these are related but distinct social risk factors. I won't harp on these points too much because you all are well aware of these definitions. But I think what's critical here is they're measuring different concepts, and very few people actually experience both loneliness, the subjective feeling of that your relationships are lacking, as well as isolation, the objective deficit and the number and frequency of connections with others. So loneliness occurs in about 40% of US older adults, social isolation about 20 to 25% of older adults, and only about 5 to 10% of individuals experience both. So it's really critical that we recognize these as separate concepts and really think about how to measure them separately. Loneliness, it has many different dimensions. As we all know, it's a complicated feeling of emotional distress. So it can include intimate or emotional loneliness. So this might include the lack of feeling companionship with a close partner or confidant, relational loneliness, so lack of friendships and support from friends or family, collective loneliness, so the lack of community or groups with shared purpose, kind of this lack of belongingness in our community, which many have experienced more during the pandemic. And then something we often see in geriatrics or palliative care or other individuals who are experiencing serious illness is existential loneliness or the loss of identity and meaning in the world. So it's a complicated area. And so I think when we're considering what loneliness measure to use, we should be thinking about what dimensions are most important to measure. This can also feed into the length of the questionnaire that we have capacity for, whether we want to have really comprehensive measures that are 20 items long versus questionnaires that are much shorter. We need to think about this, trying to avoid stigma that's associated with self-identifying as lonely. For a long period of time, this has been a major consideration why we might not directly ask people if they feel lonely. And so we might use indirect measures, which I'll get to shortly. This has become less of an issue during the pandemic when I think so many people have felt lonely that it's become much more normal to discuss these topics openly. We should think about positive and negative questions for loneliness, the frequency of measurement, and whether we'll be able to capture change over time. And then lastly, really try to focus on using standardized measures to aid in comparison. So let me jump into a few. I'm going to present 3 different loneliness measures that I've seen as being most commonly used in the literature. And then we'll pause and I invite you all to share measures that you've seen used or that have been helpful for you. So the first measure is just a single item that directly asks people whether they feel lonely. So in the last month, how often have you felt lonely? With responses of hardly ever, sometimes, or often. There's clear pros to this measure. It's short. And it's a broad measure of loneliness. So you might capture loneliness that comes from any of those dimensions that I mentioned before. Now, some of the cons are that there is a possibility of stigma, so that people might underreport their loneliness because of the shame or stigma associated with self-identifying as loneliness. Sometimes it is really important to know which dimension you're measuring. So you might not have a great understanding of what's going on there. And then there might be ceiling or floor effects. So what I mean is, there might be a much larger spectrum of loneliness that's actually out there in your community, but if you're just using a single measure, it might only capture a smaller spectrum of what's going on. And so particularly if you're seeing, you're trying to capture change over time, you might not fully capture that just by using a single measure. Okay, the second loneliness scale is an indirect measure, the 3-item UCLA loneliness scale. This is probably the most commonly used measure in the US, and it asks 3 questions. So in the last month, how often have you felt left out, felt isolated, or felt like you lack companionship? And you'll notice that all of those questions don't directly ask if people feel lonely, which is why we call it the indirect measure. And there's a similar response scale. So in total, the scale ranges from 0 to 6 points. Some people categorize loneliness as 1 point or more. Some will use higher cutoffs. It can vary from community to community or study to study. But some of the pros here. So again, it's quite short. It might avoid some of that theoretical stigma associated with identifying as lonely. It really gets at intimate or relational loneliness, although it might also capture some collective loneliness. It has been kind of the gold standard in recent clinical literature. And because there's a larger scale, there's less ceiling and floor effects. But some of the cons are that there are some dimensions that are less clear, and there's only negative questions that are asked in this scale, which can affect responses in some cases. Notably, this 3-item scale is taken from a much longer 20-item UCLA questionnaire, which is potentially better able to get at the 3 dimensions of loneliness that I mentioned. And so, you really got to consider how you want to prioritize these surveys and the time that's required. Okay, and then the third loneliness questionnaire that I'll bring up is the De Jonge-Gierfeld scale, which asks, and I totally butchered the name, I apologize, but it asks 6 different questions, which I'll let you read through. A couple of observations here. It includes 3 positive and 3 negative questions. So you'll notice the positive questions are things like, there are plenty of people I can rely on when I have problems. There are many people I can trust completely. There are enough people I feel close to. This can help to capture loneliness in different ways. And some of the cons, it is a little bit longer. It's less frequently used in the US. I have seen this used much more frequently internationally. And it's also, notably, this is taken from an 11-item questionnaire. So it is possible to get more depth here if necessary. So let me just pause there. These are 3 commonly used loneliness scales. Are there other scales that people have used or are familiar with? And feel free to post a comment in the chat, but I'll ask someone in the audience to read out the comment since I can't easily access it. All right, well, feel free to include a comment in the chat, and otherwise I'll just keep moving forward here. So let's turn to social isolation then. So again, social isolation refers to complete or near complete lack of contact with society. We're really thinking about, are people living alone? Do they have minimal interaction with their children, family, friends, their neighbors, or other community groups? And so there's a number of different ways that we can capture social isolation. And I always wanted to present at least one item measure, just so that we can include social isolation in the mix as you're doing larger assessments. This is one of the measures I like the most. It's a single item that asks about the presence and availability of confidants. So the question is, looking back over the last year, who are the people you talked with most often about important things? And you can actually ask people to list out their important confidants. People who have, no confidants, or maybe just one confidant, might be considered socially isolated. And those are individuals who are really at risk of, not being able to call on people in times of crisis, and not being able to, access the benefits of socializing, the physical, cognitive, and emotional benefits. And so this is a short measure. It doesn't assess all of the other dimensions of social isolation, whether people are living alone, their household situation, the frequency of contact and the number of relationships they have with children, family, or friends, how often they might be volunteering or going to religious groups. So this is a really confined measure, but can sometimes really help with a really critical aspect of people's social well-being, confidants. Okay, and here are 2 additional scales that are widely used and validated in the literature. The first is the Berkman-Symes Social Network Index. This was created by Lisa Berkman at Harvard, includes 12 items that assess people's marital status, the frequency of interaction with children, family members, friends, how often people are going to religious services, volunteering or participating in community organizations. So it's quite comprehensive. It's publicly available and really a well-accepted social isolation measure. There's also the Duke Social Support Index, which we've also used fairly frequently. Sometimes I like this measure because it gets at kind of different ways that people communicate with others. So, you know, are you interacting in person? Are you talking over the phone? We've also modified the index to include technological measures. Are you using the internet to interact with others? Are you using video technologies? So there are ways to modify things to also make it more useful for certain scenarios. Some of the cons here, you know, it can be really long if you're embedding these in other surveys. So just to be mindful of that, there are shorter kind of middle ground scales that are maybe 5 items long, if that's a consideration. And sometimes they're not totally updated to what we might be dealing with now. For example, some of the questions might get at, you know, are you going to church or not? And that might not be relevant to many of our community members. There's also rarely any questions assessing technology use to communicate with others, so that might require some additional modification. Okay, so those are social isolation, loneliness and social isolation in a nutshell. So let me now turn to primary data collection among older adults and populations at risk. And really, I'm going to touch really briefly on some key considerations here. If you're designing a study or we're partnering with among many different groups to ensure kind of consistent data collection.
Hey, before you go into that, Ashwin,
Sure.
there's a question in the chat, and it's from Michael at Well Connected, wanting to know if the scales have been used amongst non-English speakers and what the results have been like. And then he's commenting that they're starting to use the UCLA scale in Spanish and wondering about any experience others have had. I don't know if anyone on the talk wants to talk. Have you been using any scales? Have you done any of this yet? Is this scary and daunting? I know for some groups, when we start thinking about asking questions more formally, the usual answer is like, there's no way we can do that. And then somehow you find a way, but
yeah,
looks like Daniel has a comment.
Oh,
also.
Sure, go ahead,
Daniel. Hey, yeah, we were using the Duke isolation scale and the UCLA loneliness scale, and we translated it into Spanish. And we also were trying to do it in Cantonese as well. We were limited though, because I think that the intention was to find that the actual translation, like it had, I don't have the language for it, but it had to be translated by a specific entity that to make it to fit into the valid.
You're saying it right to make sure it's validated. You're right. You're saying it right.
And so that there isn't any type of misinterpretation or translation. So that was our challenge, and we have yet to find the translations into Cantonese or into Spanish, but we're still hoping that we will be able to do that so that there just isn't any flaws in the data collection.
Yeah, I think what's important, and I'll add, Ashwin, you can add too, is that there's some, like the UCLA, that there's papers that show the validation in different languages, and that's helpful. For some of the other skills, they don't exist. And so the thing that's important then is that for your program, ideally it's translated and back translated, as Pauline says, but that it's then a standard thing you're using in your program if it doesn't exist. And it's not like, well, Carla's going to choose her language, and then Sohan's going to use whatever she wants to use in Spanish, because that's when you get into validation issues and actual consistency. Ashwin, you were going to say some other stuff, I think.
I think you covered it. I mean, there, especially for the UCLA scale, I think there's many more papers on translation issues. I think partly because loneliness is might be culturally different depending on the community. Some of those words we use to describe loneliness are harder to translate. So it's just important to consider. I really like the idea of back translating loneliness. Sometimes we employ things like cognitive interviewing to see how people are perceiving certain scales that we use. whether we're actually getting across the right message or getting at the right concept. So I think there's a lot to be done here, just in terms of scale development to make these measures most useful for our own communities. I can tell you that personally, I've been thinking a lot about how do we measure loneliness among individuals with cognitive impairment, which is not a simple task sometimes. So I think there's a lot that we should be considering here, and I'm glad that we're all thinking critically about this. All right, any other questions or thoughts before I move to primary data collection?
Ashwin, we just had a comment come in. I was thinking that when looking at the one item question, asking if people feel lonely, the definition of lonely is very subjective.
Yeah, you're absolutely right. I think that's the challenge with the one item direct question. At least it's something. And sometimes, that's what you need. You just need that general or broad impression from the individual as to whether they're feeling lonely or not. I think many people who on this call who have experience asking these questions can weigh in. So Han and Signa, I know that you've done a lot of these surveys and had a lot of feedback from participants. This is also a situation where sometimes, we test the limits of surveys, and there might be real value in having mixed methods work, where we're doing both surveys and qualitative work to really try to get an in-depth understanding of what's going on. For example, if someone had trouble answering the question, do you feel lonely? In a qualitative interview, you might ask them to tell you more about what's difficult to answer, why it's difficult, what they're thinking about, and maybe get at those concepts in different ways from kind of different angles. So yeah, great question.
And I think to add to that real quick, Pauline, I think what's fascinating about this to me is that to me is what's fascinating about this work in loneliness, is that loneliness is completely subjective, and that is absolutely the purpose. And so there is a huge validity for saying like, hey, if you identify that word and that's what that means to you, then great, all for it. That being said, I think to Ashwin's point, that's where it's tricky and where you get into direct and indirect questions. For example, I have had patients in my practice clinically where if I were to ask them, are you depressed? The answer is no on a single item. Yet if I actually go through the standardized screening for depression, they're very depressed. And so it's fascinating and so tricky, which makes this work compelling, hard, and hard to show our value in what we're doing.
So the best example of this, and it's not about loneliness, but it was at a conference I was attending of suicide researchers. And the keynote speaker was a guy who had survived attempting suicide, which I love the fact that the keynote speaker was not a researcher. And he said, and this is applicable to this, that the suicidal ideation measures focus on asking people if they want to die. Yeah. He said, nobody asked me if I wanted to live. And it's the same thing. Are you lonely or do you feel connected? Do you want to see other people or do you, so that's what made me think of that. That's why I liked the one that had sort of positive, negative, and mixed questions.
There's actually, Pauline, that's a really good point, because there's actually in a lot of the researchy world and some of these committees I'm on talking about this nationally, there is this push to, wow, do we need to think about, as much as we know that loneliness and isolation are risk factors, how do we think about the protective factors about social connection, but we don't have good measures. And so I totally agree with you. It's almost like you need both, or you need them in different settings, but it's hard to find the right terms. But I hear you. I think that's a very powerful example you just gave. So thank you.
That's a great point. All right, so let me turn then to primary data collection. And again, feel free to stop and ask questions. So why collect data? I think Janet probably touched on this quite a bit, but really, we're going back to the National Academy of Sciences report. We're really trying to develop a robust evidence base here. This can help with strategic planning. It can make the case to policymakers or other key decision makers if we have evidence to back up claims about our programs. It can help to ensure quality and that we're meeting our clients' needs. And it can also help to enhance partnerships, either among different community organizations or even with different health systems when we're thinking about some of the different priorities that different organizations might have. So when we're collecting, so I'll speak first to just structured quantitative surveys. There are several key measures that we like to collect in order to characterize the population that we're serving or characterize our community, and also just understand who is participating in our survey so we know whether it reflects the individuals our overall program might be serving. And so I invite you to really think carefully about your community and important measures that you might want to include. Some of the key ones that we include in almost all of our surveys are demographics, so the age, gender, sexual orientation, race, ethnicity. There's been a lot more discussion on how to appropriately ask about many of these measures. So we're happy to kind of help brainstorm or think through how to most accurately identify groups in sensitive ways. There's social subgroups that we might want to think about: immigrants, people with immigration histories, or veterans. Socioeconomic status can be quite important, thinking about education, housing situation, wealth and assets, especially among older adults who might not be working or might be retired. Obtaining information on wealth and assets might be a more accurate way of learning about their socioeconomic situation. Their social situation, so whether people are living alone, their marital status, the presence of children nearby. And then technology has become so important during the pandemic, especially to assess. So access to devices, the internet, comfort using devices, barriers to using devices might be really important to understand. So sociodemographics are kind of core to any survey. Clinical measures can provide added context depending on the situation. So we might be thinking about psychiatric conditions or chronic illnesses. Often many of these conditions can be really closely intertwined with experiences of loneliness and isolation. So important to think about these conditions. Function is really critical. So ADL stands for activities of daily living. Here are all of the activities of daily living here on the right-hand side: eating, bathing, dressing, transferring, toileting, walking or moving around can be quite substantial risk factors for experiences of loneliness and isolation. Sensory deficits, hearing and vision impairment, and access to healthcare may all be relevant. Then lastly, we think a lot about loneliness and isolation, which are very broad measures. And I encourage you to also think about other measures of well-being that might be relevant to our programs that also might closely tie into experiences of loneliness and isolation. So there are a number of other social measures to consider, things like availability of social support or caregiver support or tangible support. So how often are people actually helping you with things around the house, for example. Elder mistreatment can sometimes be critical to assess. Not all social relationships are positive. Some can be negative, and it's important to be aware of that. Neighborhood safety and support can be quite important. And then, well-being can include many different domains. And so here are just a few of those domains that you might consider if they're more relevant to your programs. We talked about social connectedness. There's lifestyle and behaviors, physical health, stress and resilience, emotional and mental health, purpose and meaning. There's well-being scales, sense of self, finances, spirituality and religiosity, and creativity. So a lot of different dimensions of well-being that we might consider. Just really briefly on the logistics of primary data collection, I would just, there are many different steps before you can get a project off the ground. Things that to consider very early in the process include institutional review boards, whether this is so-called quality improvement projects, where you're really taking a look at existing processes or community programs and may not be developing a new intervention. These tend to be able to go through institutional review boards much more quickly than new or human subjects research. Making sure that we're being mindful of privacy and security concerns. So making sure that we have available secure data storage and management programs. At UCSF, we frequently use the REDCap program. And then just thinking about whether you have available data that you're collecting through your program's typical processes that might be helpful in evaluating interventions versus actually going out and recollecting data through conducting interviews. The latter of which is very time intensive and resource intensive. And so whenever we can work together to figure out how to incorporate data collection into standard processes, or that can be a much more efficient way of moving forward. And I'll just say that in conducting interviews, it's really important to think about sample sizes early on, think about things like power calculations for the outcomes that are most important to evaluating a program success. Lastly, we can just think about frequency and timing of data collection. So, ideally you collect data before people enroll in an intervention, and so that you can see the impact of that intervention. And there's ways of randomizing individuals to interventions or conducting pre-post studies. But the major point here is that we're often thinking about collecting data at multiple different time points. And so it's important to consider how frequent those interviews will be, and make sure we have measures that are capable of picking up change. Sometimes it's not just about the structured surveys, it's about combining with qualitative interviews to really provide depth to some of these surveys, particularly for a complex social experience like loneliness or isolation. All right, so that's it for me. So we defined loneliness and social isolation. We looked at a couple of different strategies for measuring these complex concepts, and briefly covered key considerations for primary data collection. So let me just pause for questions or thoughts, and feel free to contact me or really anyone in the coalition if we can be helpful in helping to think through some of these considerations. Sometimes it just takes a good brainstorming session to really come up with it, but just thinking about it as the first step. So we encourage you to, get started on this process early on, because getting it set up early can make a big difference later on.
Thanks, Ashwin. I think we will open it up to questions and discussions, and by no means are we obligated to use the entire time. I know these days people enjoy having some minutes back in their day, but want to open it up again. I think sometimes it can feel so daunting to, even if you haven't started on this path, is where do you even start? If you have started, congratulate yourself and say it's going great. And if you've started and you're saying, whoa, I need to rethink things, and then that's also okay. God knows that we've had many trials and tribulations along our path to evaluation for many of the programs we work with, as some of our partners on the screen can attest to.
Well, I'll just jump in. Hi, this is Preston Burns with the Institute on Aging, and our Friendship Line program has been a tremendous beneficiary of the knowledge and skills that this UCSF team has brought forward in terms of understanding our impacts in the social isolation and loneliness space, and making sure that we're accounting for that with some of this data collection that's been spoken about, and then evaluating that. We're very excited to be also working with our partner at Humana on leveraging healthcare data as a part of that analysis, which of course brings in a whole different perspective in terms of impact and outcomes. And I think we're all very excited to see where that goes, even if it isn't, necessarily positive. We hope it is, of course. I wanted to apologize for joining late. I wasn't able to hear most of the discussion, but I do really want to put forward, our thanks to the team at UCSF, and also that, we're continuing to be excited about this marriage of analysis, measurements, data, impact, and programming, because I think, we've faced this problem for many years with the Friendship Line of knowing it's a great service and knowing that it's of importance to folks and knowing that it makes a difference and reduces suicidology and other thoughts of suicidation and things like that. But unfortunately have never had any evidence to prove that. We've only recently, with the growing attention on this area from partners like Humana, been able to start digging into that, which is, I guess, fortunate. It's nice to have partners coming to the table and recognizing this challenge, even if they didn't do it years ago, but we definitely have that attention now. I think folks who haven't kind of connected with the healthcare community around this type of programming should certainly be thinking about it, because especially at the national level, it's on everyone's radar. We've not only got our partnership with Humana, but we've been approached by other national healthcare payers with the exact same interest in this space. So it's definitely not a use it or lose it type of a situation, but all this evidence and this work that we're all putting into this is obviously, this is probably the fruits of the work that teams like Carla's have been doing for years. So anyway, sorry to have missed more, and I wish I could be more on topic, but just wanted to throw that
Preston,
in there.
and I want to say that that's so helpful, because I think I've been talking to different members of IOA for, like, I don't want to scare people, but maybe almost a decade. The first, when we first started talking about this, like, there's no way we can collect data. There's just no way, we can't do that. And then it was like, well, maybe we can, but it's in this really messed up system. And then it moves to like, well, it's kind of in this messed up data system, but then maybe we can get a little bit of better system, and can we do something combined? And so it's been, a work of love. And, Preston and Laura, I will tell you that actually this afternoon we were looking at some of the data, and it actually looks really great. And so it looks really great. And there's some things we need to ask you more about. But it's exciting. And for me, it's exciting to see that, like, this is possible. And, UCSF people are not always 100% scary. Sometimes we are at some times, and sometimes you should avoid us at all costs, and other times we should work together. So how do you find that balance? But it's just, and for me, it gives me great excitement to see this conversation nationally. And what I want, as Janet described that she's biased, I am biased as well. I want community programs like yours to be the ones getting the Humana contracts and the United contracts and whoever it may be. And so my push for all this is because I am on the Scientific Advisory Council, and I know what's being talked about nationally, and I know what they need for the clearinghouse. And I want your programs to be a part of that if you want that. Now, not everyone wants that, and that's okay also. But there's this real opportunity to share knowledge and say, like, hey, we're doing good work. So I'll be quiet now.
So a question I have is, so often participants in programs will want to please, and especially maybe people who are elderly. Well, I'm not even going to go down that road. Just people will want to please, and therefore their responses may focus in that direction, and then also lots of times people don't have a lot of self-awareness. So I'm wondering, how does one look at data analysis with those lenses?
Yeah, that's such a great point. I'm sorry, might have been breaking up. I think I caught most of the question, but I think, Janice, some of the terms we use to describe what you're talking about, things like social desirability bias. So when people are responding in ways that maybe they formed a connection with the program and maybe it's helpful to respond positively. Or the Hawthorne effect is also a very well-known phenomenon where people act differently when they know they're being studied. So, it's tough to get around some of those issues when we're just conducting kind of observational studies, or we're just interviewing people, kind of looking at people over time. The gold standard way of avoiding that is by doing what's called a randomized control trial, where some people get the intervention and some people don't get the intervention. They're all being studied, but you can kind of see whether just contacting an individual, a program contacting an individual is helpful or not. The second ways that we do that is by trying to divorce the researchers and the community programs as much as possible. So, for example, with the Friendship Line, they love the Friendship Line. They don't really know us too much, so it gives us an ability to kind of get some unbiased responses. And so sometimes that can help. Other ways of divorcing the research versus the program, providing anonymous questionnaires, doing sometimes even those can be like pencil and paper questionnaires that you just leave so people really feel like it's anonymous. Or even thinking about having mixed methods work where qualitative researchers are separate from the program. I think those are my main suggestions. I think it's a tricky topic though, and I think particularly among many of our community, many of the programs represented here, where just talking with people can sometimes be therapeutic. So we've even found that some people would just really appreciate being able to participate in a survey, and that's therapeutic. And that's not necessarily a bad thing, but it can affect our how we interpret results, and we just need to be transparent about that and make sure that when we're presenting this to another audience, they're aware of that potential for bias.
I think to add to that, because actually we were talking about some of this earlier, is that when are people just like saying yes, 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 and not listening to the questions when you're asking? I think that's also a plug for mixed methods, right? So you're looking at your data and then you're like, is this really consistent? And then you get into the mixed methods and do more qualitative and you're like, okay, then you can delve into what's really going on. Yeah, Pauline.
Well, I was going to say, as someone who to focus more on qualitative research, initially you may run into some of those same issues of social desirability bias and how they answer the questions. But if your questions are open-ended enough and you spend enough time with the person, you're sort of establishing some trust also, which helps. And sometimes when I've done qualitative research, I've sort of done what I call the preliminary conversation, where I introduce myself to the person and I explain what we're going to be doing, and I tell them a little bit about myself, if it's relevant. And then that also, by time I actually do the qualitative interview, there's a little bit of trust that's been established without sort of stepping over that line to sort of too much familiarity. So I think that can be very helpful, but qualitative interviews can suffer from that same social desirability issue. And again, especially if they, depending on who they think you are in your relationship to the program.
Yeah, and I'm thinking too of just, what is the cultures of both the clients and the person who's, interviewing them, their connectiveness in that way, the languages that's being used, and the understanding of the cultural responses. But thank you.
And again, I want to focus on this part about what is the point of evaluation? What is your goal? You may not want to, you may not have to, and then some funders may want you to do it. And so the question is like, where are you in your program, and are you seeking that more external validation and growing the program and wanting to partner with payers? Are you fine at your current level? Or is it something where it needs to be smaller scale, where really you need to do something more simplified, which is really just more for member satisfaction, and you have nor you don't have the same incentives or drives to do the evaluation. I think when you're talking about, you know, payer partners, what are they interested in? I mean, everyone, whether we like it or not, are looking at costs and looking at healthcare outcomes. And there's also these things called, you know, for plans that are star ratings, which include like satisfaction with the healthcare plans. And suddenly what I think some of the plans are seeing is like, wow, some of these things matter. And so it's an interesting world out there that, you know, I've been learning more about in the last couple of years.
Yeah. Hello. I'm Ann Almondrell. I am with IOA, the Clinical Collaborative Program. So there was a mention around the graying area between research and quality improvement. And when I was working for United Healthcare, as part of the United Behavioral Health program, we had a whole separate department called Quality Improvement Research. And I think where it became really helpful, well, and then those of us that were actually doing the direct employee work, case management, intake, service provision for different levels of care for employer groups all over the country. And I think where it became really beneficial for most of us that were in the other side of research was to see that it was all client focused. The same way that we all think about clients and patients, anything we do has to be focused on them and the improvement of what, because that's the whole idea of research, unless I'm missing something, right? We want to do a better job for our client's sake. Quality improvement, we want to improve the way that our staff provides services for the client's sake. So I'm glad that there, in fact, I don't know if there's even a division, you know, or maybe it's one that sometimes we ourselves on the other side of receiving services kind of artificially create. But this is really exciting. I mean, I think that it's a long time coming, you know, and it takes a pandemic to do something where we basically, unfortunately, right, where we basically have to say, we are all in it together. These people, our people, the whole population is aging. We have to really be holding hands in making sure that the services that we provide this bulging population of people, because they're not going to say, well, yeah, I'm private pay, so therefore I define loneliness and depression differently, because we know that it's really all the same. Having said that, I think the manifestation of how behavior is demonstrated is so culture bound that there is a research. I don't know that it's quality improvement, but definitely research. And there we need to have very, very specific scientific questions around how do we define culture? How do we define help-seeking attitudes? How do we define communication styles across different cultures, regardless of language, of course, but just the way people ask for help. Yeah. But yeah, this is pretty exciting moments, I think, and I thank you so much for the presentation. It's very thought-provoking and inspiring. Thank you.
Thanks for sharing your thoughts and comments, and thanks for being here.
Yeah, pleasure.
Yeah, and I would just add that I think you're right that so much of this work draws on many different disciplines, and it's really critical that we bring in those disciplines in order to move the field forward. You know, I think you're absolutely right that culturally there may be different ways of measuring things or different considerations here. And so we also need to think about how can we be inclusive of different communities and groups so that we are capturing these concepts appropriately. You know, we often will rely on, here at UCSF, we'll often rely on you all to help guide some of these measurements quite a bit. And, you know, I think it's also reasonable to think about the people who are participating in these programs and what's important to them and how we might best demonstrate the value to them.
Maybe give a minute for final complaints, concerns, accolades. We take them all, and then we'll give people some time back. You can also do those anonymously in the survey you will get by email, because we too evaluate our program. So we will be consistent with what we preach. And I want to give a shout out to Sohan and Snigdha, who have just been really fantastic in getting the coalition off the ground and getting these symposiums and talks going. So thank you both for your work. And with that, perhaps get out there and get your vitamin D if you can, and be well.